Okay, we are going to start with the second oral abstract session of the meeting on pre-exposure prophylaxis, and the moderator is Benjamin Jang, who's Vice President and Chief Medical Officer of the International Association of Providers of AIDS Care, IAPAC. Benjamin.
Thank you, Jorge, and thank you all. As the Chief Medical Officer of IAPAC, I actually want to thank all of you for coming to London. There's over 200 attendees from 35 countries and hundreds of participants who are online around the world. And I think that this, for me, is an important element of what we do, which is to extend the educational and policy and scientific knowledge that we have here to as many communities and people as possible. It gives me great pleasure to also moderate the second oral abstract session on pre-exposure prophylaxis. We have 4 presentations this morning, and we'll just start right away. And the first presentation is by Anthony Nardone from Public Health England, who will tell us about estimating the impact of a PrEP program in England for men who have sex with men.
Okay, thank you very much. And I'd like to thank the organisers for this opportunity to present this study to estimate the impact of PrEP on HIV amongst men who have sex with men in England. I'm presenting this on behalf of Monica Desai, who couldn't make it here today, as well as the other co-authors listed. As you're all aware, PrEP has been widely advocated as a new tool for HIV prevention for MSM. Here in England, MSM represent the population most at risk of acquiring HIV infection. In 2012, there were over 3,000 new diagnoses of HIV amongst men who have sex with men, and that's the highest number, annual number ever recorded. We also have a network of over 200 plus open access clinics which provide sexual health and treatment and care and are well attended by men who have sex with men. And it's in a small number of these clinics that PrEP has been available through the PROUD pilot study. To inform our thinking on any possible PrEP program in the future, we wish to explore the impact of different eligibility criteria for PrEP on 3 measures. Firstly, the size of the program, how many men would actually be eligible, the impact on the epidemic, how many infections we would actually avert, and the effectiveness is assessed by numbers needed to treat to prevent a single infection. To do this, we use the GUMCAD dataset, which collects pseudo-anonymized socio-demographic and clinical information on all GUM clinic attendees in these 200 clinics. We have employed the GUMCAD dataset to estimate the number of attendees and the HIV incidence in repeat attendees for each of these 7 possible criteria listed below. For each of these criteria, we estimated the number of HIV infections averted and numbers needed to treat for 3 different coverage scenarios: 90%, 60%, and 30%. And we assumed 100% adherence and 100% efficacy. For each of the 7 criteria, we determined the number of men who would be eligible for PrEP, and the numbers varied from 74,000 for those men, which is the widest eligibility criteria, and was for all men attending for an HIV test at one of these GUM clinics, to 2,000 men for the strictest criteria, which was a previous diagnosis of chlamydia in the previous 12 months. And for each of these criteria, we reported an observed incidence that varied from 5.5% among men reporting condomless sex with an HIV positive or unknown HIV status partner to 2% among men who had 2 or more HIV tests in the previous year. So by plotting the numbers needed to treat against the number of HIV infections averted, we can show the criteria and the coverage for PrEP that would have the largest impact on the HIV epidemic amongst men who have sex with men. So among the 74,000 MSM having an HIV test, we would expect just over 1,800 new HIV infections per year. So that's in effect the the y-axis is if you go right to the end, that would be the total number of new infections you would expect. And the ideal criteria would be as far along that y-axis as possible, that x-axis as possible, and as low down the y-axis as possible, so that we would have, so in effect being as much as possible in the bottom right-hand corner. If we look at the impact of offering PrEP to all men attending for an HIV test, at 90% coverage, this point in green, we would avert nearly 1,700 new infections, and the numbers needed to treat would be 45. However, a more realistic coverage of, say, 60% and 30%, the numbers of infections averted and the numbers needed to treat rises dramatically. So that at 30% coverage here, we see that we would only avert just over 500 infections, and with a number needed to treat of 133. In contrast, by achieving a 90% coverage of PrEP for men who report UAI with a partner of an unknown or HIV-positive status, the number of infections averted would be nearly 800, i.e. 42% of our total number of infections we would expect, and the number needed to treat would be 20, and a 90% coverage in that population would be seen as more achievable. With a 60% coverage, it's not there, sorry, that's it. So there's the 90% coverage. Then with a 60% coverage, we would see, we still expect to avert more than 500 infections with a number needed to treat of 30. If we offered PrEP to men who had a bacterial STI in the previous 12 months, then at 90% coverage, that's this green spot here, we would expect to avert nearly 600 infections, approximately a third of the expected total, with a number needed to treat of 30. These analyses indicate that PrEP could have a dramatic impact on the HIV epidemic if the offer was targeted to men who report UAI with a partner of unknown or HIV-positive status, or have been diagnosed with a bacterial STI in the previous 12 months. What can be viewed as an achievable coverage for either of these criteria, the number of infections would be reduced by approximately 20 to 40%, with very low numbers needed to treat. Further cost-effective modelling is necessary to determine the optimal criteria for population-level benefit. But these results highlight the eligibility criteria that are feasible and would have a major impact on the epidemic. And I would just like to acknowledge colleagues at PHE and at the MRC, and also for your time and attention. Thank you.
We have time for a couple of questions. And we'll save some time at the end if we have for open questions to the entire panel. Thank you very much. So our next presenter is Kate Mitchell, presenting from the London School of Hygiene and Tropical Medicine on mathematical models to estimate the potential impact of PrEP for female sex workers and men who have sex with men in Bangalore.
Thank you very much. So just to give you a bit of background about the particular setting in Bangalore that we are looking at. So here, HIV concentration is very much concentrated amongst female sex workers and their commercial clients, and amongst men who have sex with men. So in 2009, HIV prevalence was about 8% among the female sex workers, and about 16.5% amongst the MSM. So there have been previous quite intensive interventions among both communities in Bangalore, and reported condom use by both groups is now quite high. So in this analysis, we used a mathematical model of HIV transmission between sex workers, their clients, MSM, and the general population, parameterized and fitted that model using data from Bangalore to estimate what the additional impact might be and the efficiency might be of PrEP if we targeted it to sex workers or to high-risk MSM. So just a little bit more background. The MSM population is a bit larger than the sex worker population and obviously has this higher prevalence. The MSM are reporting slightly lower condom use. We've got very high condom use reported by the sex workers. But on the other hand, the sex workers have a greater number of sexual partners, and then their clients are more likely to be in marital or cohabiting relationships than the MSM. Oh, sorry, getting the buttons right. So I'm going to jump straight onto the results. So first of all, thinking about how many infections could be averted by a targeted PrEP intervention in this setting. So first of all, just thinking about within the group itself that is targeted. So we looked at 4 different targeting strategies. So from left to right, those are high-risk MSM, sex workers, looking at the whole sex worker community, targeting both of those groups together, the MSM and the sex workers. And finally, we also looked at what if we targeted a subgroup of the sex workers, so those reporting lower condom use with their clients. Just say the high-risk MSM are those who are reporting more receptive and versatile anal sex, more likely to be self-identifying as MSM, having more partners, and those are the ones that are in contact with current interventions, which is why we're targeting that group. So we looked at all of the results will be for an intervention with assuming 60% PrEP effectiveness, so that's assuming fairly high adherence, and 40% coverage of the target group. So for each of these targeted interventions shown, we're averting about 20 to 25% of infections within the target group over the first 10 years of the intervention. And if we look at absolute numbers, for single groups, we're averting more amongst the high-risk MSM than amongst the sex workers, and that's probably partly because it's a larger group and partly because they've got this lower condom use. But if we look at the infections averted in the entire population of Bangalore, so taking into account transmission to other groups, now we see a greater impact targeting the sex workers rather than the MSM. And when we look at targeting both of those groups together, it's almost additive, the effect. And the sort of population level impact is about 1.5% of total infections averted if we target the MSM, and about 2.5% targeting the sex workers. We see a much lower impact just targeting this subgroup of sex workers with low condom use. They're quite a small group in this setting. We were also interested in efficiency, which we've measured in terms of person years of PrEP per life year gained. This is showing over the first 10 years. So how much of an impact do you get per amount of intervention effort you put in? So for the same intervention, 40% coverage of the target group for these 4 different targeting strategies, and assuming 60% effectiveness still. So we now see that PrEP is most efficient, and we're looking for the lowest number this time. It's most efficient when we're just targeting this subgroup of sex workers who are reporting lower condom use, followed by targeting the sex workers just in general, and followed by doing a mixed intervention targeting both sex workers and MSM. And another important thing, if we look over a longer time period, over 20 years, I've shown this on the same scale, the efficiency is vastly improved over a longer time period, so it doesn't matter what sort of time period we're thinking about. But we're still seeing the same sort of ordering. It's still most efficient if we target these sex workers with low condom use. So having identified that most efficient strategy, targeting these sex workers who are reporting low condom use, we wanted to know what happens if we don't get that targeting quite right. It's all very well in a model saying, right, we're just going to get those sex workers who say they're not using condoms so much. But in real life, what happens if you accidentally get some other sex workers in there as well? So this is just showing what happens if we get the targeting right and get it really wrong. So this is showing, as before, infections averted in the entire population of Bangalore over 10 years. With on the left, that's our existing the strategy I've shown before, where we target these low condom use sex workers, so aiming for 40% coverage of them. And then the other bars are showing what happens if, with that same amount of PrEP distributed, the same number of sex workers put onto PrEP, what if we get the targeting wrong? What if it's just randomly distributed? Or what if we actually entirely miss that group with low condom use? It's just given to those with high condom use. And on the right, showing exactly the same thing, showing efficiency for those same different what if the targeting is right and what if we get it wrong strategies. And we find that both the impacts and the efficiency are about halved if the same amount of PrEP is distributed randomly amongst the sex workers or given just to sex workers with high condom use. So if we get it completely wrong, you get about halving in your impact and efficiency. So I'll just summarise those main results. We found that PrEP could substantially reduce incidence amongst target groups in this setting. This is a concentrated HIV setting with existing high condom use. We predicted a larger population level impact in this case from targeting the sex workers rather than the MSM. And we found it was also more efficient to target the sex workers rather than the MSM, and even more efficient to target this subgroup of sex workers with lower condom use, although the population level impact was much lower in that case. And if you got your targeting wrong, if you're trying to go for this really specific targeting of the low condom users, and you mistargeted it entirely, that could roughly halve the impact and efficiency here. And also just to emphasise that PrEP is much more efficient in the longer term, so it really matters what timescale you're thinking about your impacts and returns. I'd just like to finish by thanking colleagues and collaborators on this project and the Gates Foundation who funded it, and thank you for listening.
Any questions for Dr. Mitchell? Question in the back?
Hello. Roger Tatou, Imperial College. Unlike the discussion we had earlier this morning, that's where you need to have a look at the impact on condom use because of the effect of PrEP on the client's behavior. If the clients know that he can have condomless, it will affect the currently very high level of condom in some of the population. And you have to balance, in this case, the effectiveness of PrEP with and adherence in particular, in a context where the client will request condomless sex.
Yeah, so we're doing that analysis at the moment. So looking at what happens if the sex workers who are taking PrEP reduce their condom use accordingly. And it's not, so far it's not having that much effect, but we just need to check our numbers before I say, oh, it doesn't matter. But we are definitely looking at that. I think it's important.
If I can follow, it seems like that question actually echoes the Anthony's modeling as well, that what you're really talking about are a bunch of codependent variables that should be modeled as a function, in this case, of a change in condom use and the migration of individuals from one population to another, not as a dichotomous variable, high and low condom use, but really as a time-dependent variable that shifts between the two groups, which actually winds up being a second or third order differential equation. But nonetheless, I think it's an important way to think about let's say risk decompensation, if you will, or just the changing the characteristic of one of the analytes over time.
Yeah. So we do have we have movement between those groups in the past when we've got good data on it. So as this intervention I've mentioned has been put into place, we've seen a lot of movement between the groups. So we have modelled that. Predicting what it would do in the future is a bit tricky, and we haven't attempted that yet. But yeah, it's a good point.
Right. Any other questions? Okay. So our next presenter is Sandra Führer, who is from the AVAC Global Advocacy for HIV Prevention from Paris and the United States. Will speak on civil society advocacy as a prerequisite for implementation of PrEP and other prevention strategies.
Hi all, thanks. Nice to be here. I'm going to try to cover 10 years of PrEP advocacy in 5 minutes. I think that's 2 years for every minute. So let me start. There are 3 pivotal times in the timeline of PrEP advocacy that AVAC, with partners, global partners and domestic partners, have been working through. And one of them, the first, is advocacy for research to prepare for results and make sure that there's ethical research going forward. The second one is once we got proof of concept, the next push, the next civil society advocacy need was guidelines and regulatory approval in countries. And then in tandem or even after, the third wave of advocacy is really, or the third phase is really to really target it, to figure out how to deliver, how to implement, and really target the people who need it the most. Probably everyone in this room is aware of the history of AIDS activism around PrEP. Going back 10 years ago, there were issues around ethical breaches and not enough community engagement in the efficacy trials. So, and shout out to ACT UP Paris, Global Campaign for Microbicides, TTAG, all of these original PrEP civil society watchdogs. So out of this, because the trials could not go on, AVAC and UNAIDS came up with GPP, Good Participatory Practices, is a standard for clinical trials to implement how to engage community, to make sure community is on board. And therefore, we were able to go forward with ethical clinical trials for PrEP to finally get a proof of concept. But in the meantime, before we got our first proof of concept, we wanted to, I'm going to use the US as an example, as a case study. We wanted to make sure that communities were prepared. So we started out as far as back as 2007 going to the USCA, United States Conference on AIDS, and trying to ring the bell that, PrEP is this new intervention. It's in research now. Let's prepare for this. This is potentially a really good additional tool. And we got pretty sluggish response. It ranged from sluggish to skeptical, this radical idea, not a lot of interest until it was approved. And then USCA, other organizations started implementing their own workshops at USCA. And by the way, USCA is the frontline provider conference in the US. So once we got proof of concept, there was a lot of advocacy done for timely FDA approval. AVAC organized a network of domestic advocates representing communities, and Matthew Rose is one of them, speaking eloquently at the committee hearing, the FDA committee hearing, talking about his demographic as a young gay black man, really needing another tool. Also, behind the scenes, Gilead was a little bit reluctant to actually push for a prevention label, and so there was a lot of pressure for them to actually do that. And lo and behold, we got FDA approval, and so since then there's been, everyone says that it's been slow uptake, and compared to what? This is sort of a radical medical intervention. So, but there has been a real push, and a shout out to Project Inform and AIDS Foundation Chicago and others, who really have worked tirelessly to get the message to the grassroots, along with AVAC across the country, doing a lot of media work, doing a lot of blogs that were mentioned earlier, and so much so that there's been a suite of demonstration projects. There's been the US FDA guidelines that were recently released, and there's also, most importantly, been a shift in the thinking of community, the response, especially in gay men, and earlier before it was approved, no interest, but now you could really, it's palatable, the change, the shift of acceptance, and this is evidenced by very current, recent mainstream publications, the news, New York Magazine, cover story, Sex Without Fear, New York Times, advocating pill use signals shift to prevent AIDS. Does PrEP equal a gay sexual revolution? It's time to bring HIV prevention drugs out of the closet. So I guess the take home here is that the more information people actually had about PrEP, the more they learned about, the more they wanted it, the more there was a sea change in perception. And also, just a few of us advocates were doing this 10 years ago, and it sort of took on a life of its own. The more people knew about it, it snowballed. So that was the U.S. That was our success story in the U.S. And then we also work globally. And these are just some of the countries that we've been focusing on and PrEP. And let me also stress that we don't just work on PrEP. We work on combination prevention. So PrEP is part of TASP. It's part of VMMC. And we also advocate for emerging interventions that are still in study. So we very systematically went to the countries where there were PrEP trials to make sure that they were done ethically, that communities were informed. We support advocates on the ground to actually work with policymakers, work with their ministries of health, parliamentarians, their national AIDS councils, the media, form coalitions, prevention coalitions. And it's been pretty successful. Also, Europe has been doing, the advocacy in Europe has been, it's newly forming to actually demand approval. And so I'm just going to use Kenya as an example that was spoken about earlier. They have this great new Prevention Revolution roadmap, which actually recommends PrEP for sex workers, MSM, truck drivers. They don't have guidelines yet, but they know that they need them. They even say that they need them. They're going to roll out 2 pilot projects. They're planning on it, rolling out 2 pilot projects. And the Global Fund the proposal to the Global Fund is hopefully going to include funding for the pilot projects. So now where are we? Now we really need implementation in countries that are moving towards regulatory approval. We really need to make sure these demonstration projects go forward and they teach us how to deliver, and so we've got civil society pushing on the ground in these places. We need the coalition-based grassroots work for demand for community education, and we still need to educate policymakers about the existing PrEP and next generation PrEP, whether it's intermittent PrEP, whether it's PrEP with other molecules like Maraviroc, and new emerging technologies. So the lessons we've learned over the years are that we must prepare communities, policymakers, and media during, before, and after the trials. Before, during, and after the trials. Initial PrEP skepticism is overcome with correct information. PrEP advocacy by a few eventually spreads on its own. Delayed translation of research finding into policy and practices should be expected even in the best of situations. I didn't mention Uganda, but we can talk about that after. Patterns arise predicting where troubled spots will be for forthcoming interventions. That's Uganda. Obviously, Kenya was ahead in male circumcision. It's ahead in adopting the 500 guidelines for treatment as prevention, and it's also ahead in implementing PrEP. So there's very predictable patterns that are arising. Lastly, science is the easy part. The implementation is proving to be proving to be difficult. And I want to just quote Nikos from yesterday when he said, if it exists among scientists, we can't assume policymakers will implement it. We need civil society advocacy. Thank you.
Any questions? In the back.
Just a comment. I don't think science is the easy part. If it was, scientists wouldn't be in this room.
Thanks. I actually wanted to thank Sindra for her presentation, but also to call out your reference to our friend Howard Grossman, who is a gay HIV negative HIV care provider in Manhattan, who was referenced in your media because he wrote a really compelling blog about his transition from a PrEP antagonist to a PrEP advocate in the framework of him being a sexually active gay man in Manhattan and his decision to take PrEP himself. And I think it's a very introspective insight into the challenges that we all face in thinking about PrEP and provider education about PrEP in the context of someone who is medically informed and scientifically informed. So thanks. So our last presentation this morning is from Nancine Dadem from the Jos University Teaching Hospital in Nigeria. She'll be talking about stigma as a possible barrier to PrEP acceptance in Nigeria and lessons learned from a formative study on PrEP acceptability.
Good morning, everyone. Like he said, I'll be discussing on stigma as possible barrier to PrEP acceptance in Nigeria. And these are the lessons that were learned from the formative study on PrEP acceptability. So by way of background, this formative study was conducted to explore the acceptability of ARV use as PrEP for HIV prevention in Nigeria. And some of the objectives were to identify the target group to be used for the demonstration study and to understand the concerns people may have about PrEP. And so this is largely a qualitative study. We conducted open-ended interviews, telephone interviews, focus group discussions, consultative meetings, and online survey with 65 respondents from around the globe. Here's the map of Nigeria with showing the location, the study locations with the FCT Abuja in the middle, with Benue in the middle belt, Edo and Cross River towards the southern part of the country. Our study participants were representatives of government. Most of them were from the ministries of health, partners in HIV program and research, most who came from development partners and NGOs, people who may receive PrEP, including serodiscordant couples, MSMs, IDUs, and sexual workers, and then community representatives. Here's the data table showing the data collection activities and their sample sizes. Like I said, the online survey was with respondents from around the globe. For data analysis, each corresponding study objectives were summarized and assigned to descriptive categories, and we inductively analyzed to identify themes and broader concepts. The results, findings indicate wide acceptance of PrEP as an addition into the HIV prevention package. However, stigma was a strong concern. Stigma through the breach of confidentiality, stemming from the physical layout of PrEP clinics, the organization of services, professionalism of staff, and low public education. How does this happen? For example, the types of clinics. Will the PrEP clinics be hospital-based or mobile clinics? People are concerned. How about the location of clinics, even within the hospital premises? Would they be integrated or would they stand alone? The organization of clinic services, would they be every day or will they be special days arrangement? Because even for the ART clinics, we have, for example, where patients come in on maybe Mondays and Wednesdays to access services. And another concern is with the PrEP delivery. Will it be integrated among other services? For example, will a PrEP user go through the same door to see a doctor as would a hypertensive patient do? And people are also concerned about levels of education. If people are going to confuse the use of ARVs as PrEP with use of ARVs as treatment, then that's going to be a concern because there's a lot of stigma meted out to those who use PrEP as ART. Now, how does professionalism come in? Health workers are known to shout out names of clients in the facilities, and people are concerned that this may risk disclosure. Sometimes health workers just arbitrarily, reveal client statuses to other people who have no business knowing the status of others. And the fear of harsh treatments and attitudes of health workers, this is a form of stigma on its own. And so people are concerned. We remember not through this study, but there was a patient who told us in another study that she felt stigma for the first time in the clinic because of the harsh attitudes she received from her healthcare provider. And so the recommendations are to have PrEP into daily general health services where everybody sees the doctors. For drug pickups, everybody goes through the same door to see the pharmacist, and this should be on a daily basis so that people don't pry as to why do you go to clinic only on Wednesdays, why do you go only on Fridays, for example. And it is recommended that healthcare providers should be trained and retrained on confidentiality. This is very important. And also to identify sources of stigma in the communities and to create awareness. There was an explanation from the southern part of the country where people said commercial motorbikers were in the habits of revealing people's statuses, and this is because they're able to provide almost like door-to-door services to passengers. So they pick you from your doorstep and then they take you to the hospital. So they're able to know where you're going to. So this is a concern. And then if people do not understand what PrEP is, they will easily confuse it with PrEP, with ARVs as treatment. So they have recommended a robust public education strategy using community advocacies where you engage traditional leaders, religious leaders, and everybody that matters in the community, and the use of both print and electronic media in order to create awareness. So our conclusion is that if these recommendations are implemented, then the PrEP demonstration project in Nigeria could be effectively utilized, and is scheduled to begin before the end of the year. So we hope that the recommendations are going to be implemented. We want to appreciate our funders, the Bill and the Melinda Gates Foundation, all study participants, NACA, and the PrEP Formative Study Team. We have 2 members with us. Thank you for listening.
I'm afraid we're out of time, and Jorge's giving me this. So I want to thank our speakers for their excellent work and their presentations. I encourage anybody in the audience to chat with our presenters over the coffee break. Thanks. I'll return this to Jorge. Thanks.